Welcome to our online immunisation course education video. This video will demonstrate the steps involved in the vaccination process, which includes the room and clinic setup, the pre-assessment and consent procedures, vaccine administration techniques, and post-vaccination procedures. Remember, you can always watch this video again if you need to. Ideally, the clinic room should be set up appropriately. If you see mainly children in the clinic, then the use of different pictures and mobiles will assist in distracting a child. Make sure you have an anaphylaxis kit in each clinic room which is accessible at all times. Having a vaccine fridge within the vicinity of the clinic would allow all vaccines to remain in the recommended cold chain temperatures until needed. Alternatively, a monitored esky may be used if the fridge is located in another room. Be sure to check the vaccine fridge temperature and the cold chain cards each day and record this information on the temperature monitoring chart. Set up a tray with a disposable liner, arranging all equipment that will be needed for the vaccination clinic. Make sure the clinic tray and yellow Sharps disposable container are accessible but out of reach of young children. Using a running sheet in the clinic helps with the final count at the completion of the clinic, allowing for a quick follow-up of discrepancies in the final count. When meeting a client for the first time, always give your name and role. Next, you will need to check the documentation in your child health record or any other immunisation history documentation provided. If documentation is incomplete, further information can be obtained from the Australian Childhood Immunisation Register for children less than 7 years of age or the client's previous doctor or immunisation provider. Remember to ask if the client identifies as Aboriginal. In order to assess the vaccinations required, you must take into consideration the person's age, the minimum interval between scheduled vaccinations that need to be observed, whether a catch-up vaccination is needed, any risk factors that may require additional vaccines, and Aboriginal status. The pre-vaccination checklist also helps to determine if the person is medically fit for vaccination and any additional vaccines that may be required. This assessment must only be undertaken by a registered nurse or medical officer. Once the checklist has been completed and assessed, you can advise the parent or client what vaccinations are due today and consent must be obtained. Ensure the parent or patient has had time to read any information you have supplied. The consent resource folder can be used to discuss the risks and benefits of vaccination. Remember to give the client an opportunity to ask questions about the vaccines and also let them know of the recommendation to wait for 15 minutes following the vaccination. As you know, for consent to be legally valid, it must be given by a person with legal capacity and of sufficient intellectual capacity to understand the implications of being vaccinated. Consent must be given voluntarily and given for the specific vaccines to be administered, and can only be given after the risks and benefits of these vaccines have been explained to the individual. You can now prepare the vaccines. Before you remove vaccines from the fridge, it is important to check the temperature to ensure vaccines have been stored within the correct temperature range. Select the required vaccine from the fridge or esky and prepare on the tray. When removing the vaccine from the packaging, always check the vaccine's name, batch number and expiry date. Vaccines come in different appearances and presentations. Nurses need to be aware that some vaccines, particularly combination vaccines like Infanrix Hexa, require reconstitution with the syringe and a vial. Other vaccines like MMR and varicella require reconstitution with the supplied diluent. Check for any particles that may be floating and any abnormal colour. Do not use if you are concerned about the contents of the vaccine. There are 3 different administration techniques for vaccines included on the immunisation schedule. These techniques are oral administration, intramuscular injection, and subcutaneous injection. As you know, the oral rotavirus vaccine is the only oral vaccine on the schedule, and Rotatec is the rotavirus vaccine used in South Australia. Rotatec is recommended for infants at 6 to 8 weeks, 4 and 6 months of age. Some other states use Rotarix, which is 2 doses, and recommended at 6 to 8 weeks and 4 months of age. It is a good idea to give the oral rotavirus vaccine prior to any injections, as it will be difficult to administer if the child is distressed or crying. When administering the oral vaccine, ask the carer to hold the infant in a nursing or feeding position, as you can see here. Administer the entire vaccine slowly toward the back of the inner mouth cheek, between the cheek and the gum, and allow the infant to swallow. As there is 2 mL of the Rotatec vaccine, you should only give small amounts at a time. If you are giving the Rotarix vaccine, it comes in a different presentation and is only 1 mL. If the infant spits out a small amount, you do not need to repeat the vaccine. However, if you think the infant has not had enough, you can consider giving another dose immediately. Try not to administer the vaccine too far back into the mouth or directly into the throat, as this may stimulate the infant's gag reflex. To make sure the infant does not spit the rotavirus vaccine, you can stimulate the rooting and sucking reflex by touching the lips and mouth. For infants who are 5 months and older, lightly stroke the throat in a downward motion to stimulate a swallow. This baby is also receiving the oral Rotatec vaccine. Many infants receiving the oral rotavirus vaccine will offer some level of resistance to the insertion of the oral applicator. In some babies, the administration of the oral vaccine may take several minutes. Discard the empty applicator and cap into an approved biological waste or sharps container. Sharps containers are normally yellow and clearly labelled. We will now look at how to position an infant prior to intramuscular vaccination. This infant is presenting for her 4-month vaccinations and will be receiving 2 intramuscular injections, 1 in each vastus lateralis muscle. This is the preferred site because of its larger muscle size. In this section, we will demonstrate 1 needle in each site. Later, we will show you how to administer 2 injections into each site. When seeing infants less than 12 months of age, you can use this cuddle position. Position the infant in a semi-reclining position on the lap of the carer. The infant's arm that is near the carer will need to be restrained under the carer's arm or against the carer's chest. The infant's other arm should also be held securely by the carer. This helps to keep the infant still. By flexing the infant's knee, you can encourage relaxation of the vastus lateralis muscle. An alternative to the cuddle position is to lay the infant on the examination bed, with the infant's head positioned away from you, and the carer standing beside you to immobilise and distract the baby. By cupping the patella in the non-injecting hand, you can keep the infant's hip and knee flexed prior to the injection. You may need to remove the nappy to properly identify the anatomical landmarks and fully expose the injection site. The upper anatomical marker is the midpoint between the anterior superior iliac spine and the pubic tubercle, and the lower marker is the upper part of the patella. Draw an imaginary line between these 2 markers down the front of the thigh. The correct site for intramuscular vaccination is lateral to the midpoint of this line, in the outer or anterolateral aspect. Be careful not to inject into the anterior aspect of the thigh, where neurovascular structures can be damaged. Tell the parent to hold the infant firmly to reduce the risk of a needle injury to the infant, parent or nurse. Using a 23 gauge, 25mm needle, pierce the skin at an angle of 90 degrees. It is safe to insert the needle to the hub. Following the injection, cover the site quickly with a dry cotton wool ball, using tape only if required. In this case, tape is used to stop any blood spots going on mum while the second injection is given. When you are vaccinating, you do not need to draw back on the syringe plunger prior to injecting a vaccine. But if you do this and blood appears in the needle hub, just withdraw and replace the needle and select a new site to complete the injection. As long as an injection angle of greater than 70 degrees is used, the needle should reach the muscle layer. Gently apply pressure, or ask the parent to apply pressure for 1 or 2 minutes, but not to rub the site, as this will encourage the vaccine to leak back up the needle track and cause pain and irritation. Here is another child receiving their 4-month vaccines. Note how the nurse gently lifts and turns the baby to expose the thigh. This makes it easier to identify anatomical landmarks and administer the injection. Some babies have nice large thighs for vaccinating. However, if you are administering the hepatitis B vaccine to a newborn or the 2-month vaccines to a premature baby, you will notice a smaller muscle mass. The 25 gauge 16mm needle is recommended. If you are using the 25 gauge needle, make sure you inject the vaccine slowly over 5 seconds to reduce injection pain and muscle trauma. This child is 12 months of age and she will be receiving 2 intramuscular injections, 1 in each deltoid. This is the preferred injection site for this age group as it reduces the risk of limiting the child's mobility. By positioning the child sideways on the carer's lap, ask the carer to tuck the child's non-injecting arm under the carer's arm and behind the back of the carer. The carer then holds the arm to be injected securely by the elbow, close to the child's body. Securing the child's legs will help to stabilise the child. Although this is the ideal position, it is more difficult for a parent to restrain the child and can often be a challenge for both the parent and the nurse. An alternative position, as demonstrated with this 18-month-old child, is to position the child facing away from the carer, with the child's legs straddled over the carer's lap. This position can be used for 4-year-olds also. However, as many 4-year-olds will struggle, you may consider asking the parent to lock the child's legs with the parent's legs and hug the child's folded arms, holding the child firmly to their chest. Once the child is held securely, expose the child's arm completely from the top of the shoulder to the elbow so that you can locate the deltoid muscle. You can do that by rolling up the sleeve or removing some clothing. The injection site for the deltoid area is halfway between the shoulder tip and the muscle insertion at the middle of the humerus. Draw an imaginary inverted triangle below the shoulder tip using the identified anatomical markers. The site for injection is the middle of this triangle. A single injection can be given into each deltoid muscle using the same technique as previously seen. Note how the nurse pauses to ensure the child is secure and not moving before she inserts the needle. Here is another example of a child receiving their 12-month vaccines. This child needs to be restrained securely. Note how mum is holding his hands to prevent them moving about. Again, the nurse pauses before administering the vaccine, waiting for the child to settle. This 18-month-old Aboriginal child also needs 2 injections, which includes a subcutaneous vaccination. As can be seen here, the subcutaneous needle is shorter in length compared to the intramuscular needle, as it only needs to go into the subcutaneous layer. This subcutaneous injection will be administered over the deltoid muscle area. The subcutaneous injection is administered at a 45-degree angle to the skin, using a 25-gauge 16mm needle. For infants less than 12 months of age who may be receiving a subcutaneous injection, for example some types of influenza vaccine, you would administer over the anterolateral thigh muscle area. At times, 3 or 4 injections may be required at one visit for situations such as an additional influenza vaccine at 6 months of age, or a hepatitis A vaccine and influenza vaccine for the Aboriginal child at 12 months of age. When 3 or 4 intramuscular vaccines are to be given to an infant at the same visit, 2 injections can be administered into the same anterolateral thigh, as long as they are separated by at least 2.5 centimetres. Remember to record the location of each injection so that if the child does experience a local reaction, you would know which vaccine caused the reaction. For young children, when 3 or 4 vaccines are to be given and the deltoid muscle is adequate, a second injection can be given into each deltoid muscle as long as it is separated by 2.5 centimetres from the initial vaccine. This may be with an 18-month or 4-year-old child, as they would have a larger deltoid muscle mass for 2 vaccines. If the deltoid mass is too small, the vastus lateralis in the thigh is an alternative site. If you do inject into this site, make sure you give the least locally reactogenic vaccine so the leg mobility is not greatly impaired. This young adult has requested the Boostrix vaccine. For older children, adolescents and adults, vaccines should be administered into the deltoid area. Ask the client to sit in a straight-backed chair, feet resting flat, and their forearms and hands in a relaxed position on the upper thighs. Keeping the arms flexed at the elbow will allow the deltoid muscle to relax and be a less painful experience. Using the 23-gauge 25mm needle, you can pierce the skin at an angle of 90 degrees, safely inserting to the hub. Remember that as long as you use an injection angle of greater than 70 degrees, the needle should reach the muscle layer. You can administer a single injection into each deltoid muscle. The injection techniques for both the intramuscular and subcutaneous vaccinations in adults are the same as those demonstrated earlier on the infants and children. You may need a longer needle for the very large or obese clients, and a 23-gauge 38mm needle should be used for intramuscular vaccination. It is quite normal for infants, children and parents to be upset following their injections. By comforting or distracting the child immediately after vaccination, you can easily reduce anxiety and discomfort for both the parent and child. You can ask the parent to try swaddling or holding the infant gently, or you can shake a noisy toy or play music for the young child. Don't forget to discuss the management of common adverse events or side effects following immunisation, and give them a copy of the Vaccine Safety Information leaflet, pointing out the contact phone number if they have any concerns or need to report a reaction. Once you have given all the required vaccines, you must record all relevant details of the vaccines given on the personal immunisation record. Some vaccines have the removable stickers with the batch numbers. These can be used in the Child Health Record Book or the Personal Record Card. These details should also be recorded in the clinic or practice records. For children less than 7 years of age, all data must be submitted to the Australian Childhood Immunisation Register, and for adolescents receiving the HPV vaccine, all HPV data must also be submitted to the National HPV Vaccination Register. As there is a risk of experiencing an adverse event immediately following vaccinations, remind the parent or client to wait in an observation area for 15 to 30 minutes where you can clearly see them. You should also remind adults who have been vaccinated not to drive or operate machinery for at least 30 minutes following vaccination. Remember to encourage your client to bring the immunisation record for each visit. Finally, provide advice that if they have any concerns about any reaction to the vaccine, they can contact their doctor or immunisation provider, the hospital, or the state health department.